Let us now continue on to tibial fractures. Imagine a car bumper striking the leg of a road crossing pedestrian. The tibia and the fibula may fracture. The fracture may be simple or compound. The wound can be from inside out or outside in. The outside in wound can be of Gustillo grade 1, grade 2, or grade 3, depending on its size and damage to the skin. Wounds are managed by dealing with infection, dead space, and skin cover. Next, notice the large medial subcutaneous surface of the tibia and the scanty muscles attachments on it. This feature gives scant vascularity. The intra-osseous blood supply, which comes through the nutrient artery, traveling through a long bony canal in the cortex, called the Volkmann canal, is disrupted by the fracture. So, the bone is ischemic inherently. There is infection, and both contribute to non-union, which is much more probable in double fractures, in comminuted fractures, in infected or exposed fractures. This may leave large bone gaps, and the internal implant, which causes the least interference with muscle attachments, is a closed interlocking nail, and therefore that is preferred as a treatment of fixation of tibial fractures. Simple fractures should be reduced by hanging the leg from the edge of the table to adapt to the normal anterior curvature of the tibia, and then they are retained in a above knee POP which prevents rotation, and when the union has become sticky, then the POP can be a patellar tendon bearing POP till the union is sound. Then you give physiotherapy. Also notice the anterior fascial compartment between the anterior surface of tibia and fibula, the lateral compartment where the peroneus longus and brevis exist, and the posterior compartment is split by a fascia connecting the tibia and fibula into a superficial posterior compartment and a deep fascial compartment. See that all the fascia are attached to, all the intermuscular fascia are attached to the fibula. So if you remove the fibula, all compartments would be decompressed. Therefore, what happens that when there is injury, there is inflammatory edema. Edema in a closed fibro-osseous space causes increased pressure and compromises the vascularity, distal vascularity, and can even lead to gangrene of the foot. Therefore, this edema-ischemia cycle, this swelling and ischemia cycle, needs to be closely monitored in closed fractures and managed by removing the fibula. If you remove the fibula, all fascia will become decompressed. Otherwise, you may have to do extensive fasciotomy. The gap in the tibia caused by bone loss is managed by Illizhorov Technique, where a proximal corticotomy and bone transport by Illizhorov Technique covers the gap. Alternatively, the gap can be covered by bone grafting. In the upper end of the tibia, if there is a valgus or a varus, the femoral condyle can split. There is a split on the lateral side. Depress, the depression is on the medial side, and rotate the tibial condyles, and can fracture these tibial condyles from the shaft of the tibia, as you see in this X-ray. As the anterior tibial artery is plastered to the tibia by the intraosseous membrane, it can be damaged, leading to huge hematoma and distal ischemia because of the Edema-Ischemia cycle. In the knee, the cruciate and the collateral ligaments may be destabilized. The tibial tuberosity or ligamentum patelli may be avulsed. The menisci may be injured. And there is a hemarthrosis within 6 hours of injury, which shows fat globules on aspiration. This has to be differentiated with post-traumatic synovial effusion in the knee, which appears after 6 hours of injury. The hemarthrosis should be aspirated and the knee thoroughly washed, because this prevents suprapatellar pouch adhesions because of blood, and that would ultimately prevent knee flexion. The fracture has to be exposed. The interposed fragments, which you see plenty here, have to be removed. Intercondylar reduction is achieved by correcting the depression, rotation, and the split. And fixation is achieved by a transcondylar compression screw. The reduced condyles are then aligned and fixed to the shaft of the tibia by plate and screw. Infection is prevented, detected, and treated. Knee is mobilized as soon as possible within limits of pain, and quadriceps and active exercises are begun to prevent wasting of the quadriceps. After union is sound, then gradual weight bearing and physiotherapy is given till full return of function. Associated fracture of the neck of the fibula can damage the lateral popliteal nerve, supplying the dorsiflexors and everters of the foot. This results in a high steppage gait, where the foot drops in the swing phase so that the toes do not stub against the ground to allow ground clearance of the toes. The hip and the knee would hyperflex. This is called as the high steppage gait. So this happens when the walking starts and has to be treated by an orthotic device like a toe raising appliance, a below knee caliper with posterior check, or an ankle foot orthosis, or AFO. This you have to continue the orthotic device till the nerve recovers. If at the end of 9 months the nerve does not recover, then to achieve dorsiflexion, active dorsiflexion, you can do a tibialis posterior transfer to the dorsum of the foot. Or to prevent foot drop, you can raise the posterior part of the body of the talus to block against the posterior margin of the tibia, which is called as posterior bone block. Or you can do a Lambranidis triple arthrodesis, and this is also acts like a bone block, and these 3 operations can be done to treat residual foot drop.